Well, hello everyone. Thank you so much for joining the Agents of Change training. Today we're covering a 1 hour topic on risk management with Sharnisha here. And we're super excited to learn about this topic because it can be something that we're addressing across any population and clients that we're serving. So we're really excited to learn about all of what she has to teach us here today. But before we get into the really great topic, I just want to introduce ourselves. My name is Bonnie. I'm the Agents of Change Continuing Education team lead here, so providing you all trainings. I have a bachelor's and master's degree in social work. I have various experience as a clinician with group work, migrant work, foster children, different things like that. Also an ASW committee member. So lots of things and experience as far as social work. So I'm really excited to kind of see what information Sharnisa has to give us on risk management. Because again, no matter what population we're serving, we can come across what is important to address with risk management. A little bit about Sharnisa. She is a licensed clinical social worker, R, and that's a special license in New York that they get to have as far as having that practice. She does have 15 years of clinical supervisory experience. Of course, also experience with leadership experience across outpatient mental health as well as community partnerships. Also telehealth, because that's something more common that we're experiencing now, right? So hopefully this information is really, really insightful for you all, and has experience in higher education. So with the college, university experience as well. She has her bachelor's and master's of social work from Temple University and has been licensed in New York since 2014. And so throughout her experience, she's going to be sharing with us as far as those really practical insights from clinical work, in order for us to really help our mental health professionals who are tuning in today on how to approach risk management with modern practice. Again, kind of that take of whether it be in person or virtual things, we want to make sure that you have the right tools on how to approach risk management with your clients. So, as we get into this, we want to share why this is important, and we'll cover a few topics here. So, of course, this is something really important because risk management protects our clients as well as ourselves, right? Changing the practice landscape as far as um, what is it that we're doing to cover our basis, of course, any crises that are coming up for us, and the clinical well-being, right? So we're going to go ahead and start our conversation here and get to learn from Sharnisha. So if you can share with us, what is risk management in social work today?
So first, I just want to say I'm super excited for this. And if the answers get a little long-winded, you can always redirect me because this is a topic that I'm pretty passionate about. Um, I will say that what risk management really involves today is looking at the whole person and thinking about risk factors that can um, be something that we need to focus on in the face-to-face environment as well as the virtual setting because they do present like different types of risk depending on the setting. And I think it's also important to not just focus on the risk factors, but also what are the protective factors that that individual may have, whether that's a support system or if they've had intervention with counseling before, if they've ever had any prior attempts, anything along those lines, just important information to know.
Thank you. So thank you so much for sharing that. How is your understanding of risk management evolved over the past several years?
So that's a great question, especially with being in telehealth right now. I think I've moved from just thinking of our typical like suicidal ideation, homicidal ideation, APS, CPS, to really thinking about how sometimes seniors may be at risk for like financial abuse or maltreatment, or how individuals with certain disorders such as like agoraphobia or hoarding, how there are some risk factors that may impact them, as well as the medical piece. It's kind of hard to look at that scope because we're always told to stay in our lane, but when you're meeting with someone virtually, a lot of times they're sharing additional information that maybe you didn't ask for, but now you have it in your lap and you need to do something with it. So I think that that's where it's really evolved to, just going beyond the basics that we're often taught in our programs.
Yeah, thank you for sharing that. It is important for us to kind of look at this as a whole, right? And so with that being said, what do newer clinicians maybe misunderstand about this?
So I think newer clinicians, sometimes it's hard for them to balance self-determination with risk management and really knowing where that line is drawn, as well as being able to understand how to manage the medical piece and the physical piece of that. Like, what do I do? What's my role? I'm not a doctor, I'm not a nurse. And that's really important. I think sometimes that's minimized. People will document it. They'll say, like, a client has reported shortness of breath, or a client has documented blood pressure of 140 over 120, but then it's like the next step, what to do with that. And I often talk to, and I know we'll probably get to it later about documentation, but I often talk to newer practitioners about the concept of basically your documentation is really alarming and it's saying there's a fire, but because you didn't do anything, you're actually kind of, when the fire department gets there, say, hey, it was a false alarm, there's no fire, but they see all the smoke and they know there's a fire somewhere. So I think that is like a struggle or something that's usually missed by newer clinicians, that what to do next.
Yeah, and it's definitely difficult to notice maybe some of those really important fires, as you mentioned, or the smoke, or maybe just some other things where we kind of like smell something and we're like, wait, something's off, right? It's starting. Um, and so this can create a lot of fear of how do we make the right decision. So, how do you explain it without making it sound fear-based as far as making these decisions for our clients and as clinicians to protect ourselves?
So I think it's really important just to normalize the conversation, right? That sometimes there's this misconception that if I ask you a question, that that's going to make you actually do it. And so if we think about our whole CBT, people have thoughts all day, right? So I could, if I didn't eat breakfast before this meeting, I might be thinking I'm super hungry, but I don't just jump off the meeting and then start eating, right? It's a thought, and there are certain skills and things that you use to say, okay, well, after the meeting, and maybe I'll have a piece of candy now so I can continue this. And so that's kind of like the same thing with risk management. You just have to ask the question. And that's a very normal part of the conversation. Depending on life situations and circumstances, anyone can really have some risk factors there. And so it's just important to make this is common. We can't do anything to make it happen. And even this is kind of an unpopular opinion, but we really can't do anything to stop it from happening either. Like, we can't control people. What we're really trying to do in risk management is harm reduction on one thing, and also kind of letting the participant or the patient consumer know that we're there for them as a support. But oftentimes our participants will show up and tell us everything's great. And then they go home and that doesn't match what they told us. And so as we move on with the presentation and the questions that you're going to ask, I know we're going to get in a little more into like what that looks like and what can we do. But I think understanding that portion of like, we can do a lot of preventative work, but we can't control someone's decision, really helps us and kind of limits that burnout and kind of sets um, that line in the sand of trauma for us as being the vicarious trauma that sometimes comes with that, because we can get a complex sometimes to feel like we can control this, we can stop this. And by all means, we're going to offer support and do the best that we can, but this is also something that we can't control. I talk to clinicians sometimes of thinking about it. If you're a parent or if you've ever been around children, just think of like potty training, or when you're asking them to do something and they give you that first no, right? And you're trying to like bargain with them, ask them to do things. And a lot of times they still say no. And you give them consequences and all of that, but it doesn't change the fact that they didn't do what you asked them to do. And so it's important that we kind of just keep that in the back of our minds when we're working with participants, whether it's risk management or something else.
Yeah, that's definitely key, especially with burnout, like you mentioned. And hopefully we can take that with some understanding, especially if we're newer clinicians, because it's also something we learn over time. But hopefully any of us that are newer to this field can definitely take that as a reminder as we practice day to day, right? I also think of kind of we can lead a horse to water, but we can't make it drink, right? So we provide all these tools, and we're here to learn about what tools we can learn about, but of course we can't force anyone to drink it. So kind of just like that as well. So thank you for your explanation because that's something interesting to kind of see it as too, keeping those in mind, especially when it comes to risk management and other um, like professions that kind of come into play with our clients, right? Not just social work, not just mental health or other things, but also maybe school, medical, things like that, and keeping that in mind. And so with this, of course, it's kind of important to kind of assess our client as a living process and what are all the things around and connected to our client. So, how do you continuously assess risk without making the client feel maybe scrutinized or that there's lots of questions going on that we're up to something, right?
Yes, so I think that it really does depend on the individual. Some clients like it to be a little bit more conversational. So it's kind of just something you introduce through your, you know, what goals did you meet this week and kind of talking and following up with those questions. Then there are other people who really do like the routine. So there were some patients that I would say, okay, well, same station, same music on this week as it was last week. I'm going to go through these questions. We're going to ask them and, have that conversation. And some people they like that. Whatever it is, I think you just have to be genuine and have that rapport, making sure that you're using like your GAD-7, your PHQ-9, your Columbia, your DOS-21, whatever it is that you use for assessments, because once the patient is they're used to that, they're going to expect that. So it's like they might just be like, and it's also in the way that you frame it. So I know sometimes clinicians and might struggle with this, but for example, when you're working with someone that's maybe 80 and they had a suicide attempt when they're 10. What happens is that clinicians really struggle to have that conversation. They're like, that was 70 years ago. I don't want to bring that up. And so, from that standpoint, again, if it's conversational and it's rapport, I may say something like, hey, so, how are you able to manage to keep yourself safe for 70 years? It sounds like you've done a great job. Can you tell me a little bit about that? So, as the client's talking about that, the same information that I could get from doing an assessment, I'm going to get from that. And so that's what I mean by making it conversational. And then also, I probably wouldn't call it a safety plan at that point, or maybe not even a relapse prevention plan, but I might say, this is your wellness plan, how we're going to help continue to keep you well. So I think that that piece is important. Another thing that I would want to stress is when I review documentation, sometimes I see people have denied, and sometimes I see people have none reported. So what happens is a lot of times there's none reported because we didn't ask the question. We make assumptions. Hey, I've been meeting with Bonnie for 10 weeks now. She's never reported anything, so I'm going to put none reported. It's not necessarily completely dishonest because you didn't report anything, but you also didn't report anything because I didn't ask the question. So it's important to continue to ask those questions, and then you're able to put denied, and that is denied because I've received that response from you. So that's what I would, recommend in those cases.
Yeah, thank you for sharing that. And with this, I think it's important to kind of note some of those special cues of what not only the question that we're asking and making sure we're asking the questions, right? Just as you mentioned, but what are some subtle cues that clinicians can look for, or maybe we miss from time to time that we can pay attention to now?
So definitely like changes in the person's voice, changing some of their behaviors that they're talking to you about, watching the body language, like is it closed off? Is it different from what they used to have? Or the opposite, like is there pressured speech? Are they overly happy now? And it seems like, well, just last week, this was not how they were presenting. And there's really no explanation for the change. Changes in the way they communicate with others and maybe changes in other dimensions of the health too. Like, so if they're saying, I actually stopped taking my blood pressure medication, or I'm no longer checking my BGLs, whatever happens, that type of talk is important to watch out for.
Yeah, definitely. Thank you for mentioning that. As far as virtual goes, are there any like tips and tricks, things that you watch for? Because it can be a little bit difficult to um, look at all of the body language, right? Because sometimes it's easy to kind of look at the hands or how we're like crossing, but it's hard to see if we can't see all of our clients. Any?
So what I find sometimes with in virtual settings is asking people where they are. Like you know that they're at home, but sometimes people may say, "Well, I'm laying down in bed. I haven't gotten up out of this bed in 3 days." Like being asking like those follow-up questions. Also, sometimes people may go onto the camera for the beginning of the session, but then make a request of like, "I just need to be off camera for the rest of the time." The voice you can sometimes pick up on too, like those inflections, which is really important because some sessions I've heard people doing by phone, which is even harder. So you're not seeing anything. So just making sure if you see the tone of the voice, the inflections of the voice. There are also times where sometimes virtually, if I'm concerned, I may ask if there's anyone else there with them or have family members been noticing any changes in their behaviors. Because I will say, sometimes it's hard for me. I'll just no, again, normalize it. Sometimes it's hard for me to know that I'm a little bit irritable, but if I ask my children or my husband, they have tons of examples. So they're a good checkpoint. Is there anyone like that? Like if you're having a visiting nurse or any of your children that are calling or your neighbor that comes by, anyone that's noticing that. And, you know, the other part is like supports, like some people might go to church. So I may say to them, like, oh, when's the last time you've been to church? Or, when you got your ride from church, have they noticed anything that's different? When's the last time you saw your primary care physician? So it's really about asking the follow-up questions and then letting that be natural because there's another part of us as clinicians, especially newer clinicians, that we can tend to just question, 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 question. So it's like an interrogation. And that's definitely not what you want. You know you need this information. And I don't care how long you've been a social worker, no one wants to really hear that someone is contemplating suicide. Like that's not what you want to hear. So anyone who hears that, or you don't want to hear about your clients being, mistreated, there's automatically kind of like a gut of like, oh, here we go. Man, I want to make sure I cover everything. So I don't believe that 100% goes away for any of us. So that's really important for newer clinicians to know too, and that you want to trust that gut. Like if something's telling you this is not okay, you want to follow up and kind of ask those questions and seek supervision. I think the assumption a lot of times is that, hey, I have my LCSW or I have my LMSW, and so I should just know. And just because you have your clinical license doesn't mean that all of your treatment or all of your education or all of your experiences are based in clinical. Like some people work in school settings and there are risks there, but those risks there look different than maybe working virtually with primarily the geriatric population. It's just a different, scene. So it's important to seek supervision, and then also, if you're not comfortable with your supervisor, you really do need to seek out some mentors, or if there is like a, consultant that you can reach out to that maybe you don't share any of the PHI, of course, or anything like that, but that you can get like a general sense of support. And even like this, CEUs, take them, they're needed. A lot of times we can feel pressured that we just have to take them like, okay, I need 36 in 3 years and I'm just going to take random ones. I understand that pressure to have to do that sometimes of the way our work schedules are and just life in general. But it's also really important to take those CEUs that are going to pour back into you and pour back into your practice. So, mix it up and make sure that you're getting that. That would be my feedback.
Thank you for sharing that. Yeah, it's definitely important for us to kind of acknowledge all of these points that you're mentioning from our clients of what we see, and also the relationship that we're building with them, or for newer clients. And so, thank you so much for mentioning, seeking that support and looking out for that education that we're needing. We're just learning, right? Pouring into our cup. And as we pour into our cup, that allows us to practice better or maybe in a sense also come back to work in a way that's refreshed in a new perspective because as we're growing in our profession, so is time and new trends and things, and we kind of need to try to stay updated with that. And we're working with human beings, so no case is the same, right? Just like with mechanical things, it's totally different. Mechanical things can be step-by-step process, and we have a step-by-step process with this, but every human being is different. there's lots of changes going on. So we hope that you learn a lot here in this hour. Um, and with that being said, when we build rapport with a client, we've seen them for some time and we're asking these questions, we're having these conversations. How does risk change once there's trust established with a client?
I think in those moments, clients tend to be more open and honest. I like to encourage people to always remember to review like confidentiality every session. I know some people are like, well, I wasn't trained like that. We have rapport already. It's kind of redundant, but it's really important because if you and I are working together, and especially if you're like a mandated participant, when you first get there, everything I say probably sounds like Charlie Brown, womp, womp, womp. Like you're not even paying attention. But then once we have that rapport, it's likely that you're going to start telling me some things, and some of those things may be reportable. And so I'm not, I shouldn't expect you to remember the first four visits when we didn't have that rapport and you weren't really probably into what I was saying to now remember that. So, it's important to remember that step and to remember that as trust grows, it's probably going to grow that they're going to be more open and transparent with you. So that's really important. The clinicians also need to be mindful that it's not so much that you're giving advice, right? So you're teaching them coping skills, but it's still their plan, because what's going to happen as that trust starts to develop and expand is that the participant may start taking your word to almost be like, for a lack of better words, they're God. So you said it, it's got to work. And there could be a huge problem with that, especially if it doesn't work out, because now they're coming back to you and saying, this is your fault. It feels great when it works out. It's like, yeah, I'm a great social worker. It does not feel so great when it doesn't work out. So I think it's always important to kind of redirect them that you're here to provide some of your clinical experiences and your education and experiences that you have with working with other participants and all of that. But ultimately, they're aware of the things that they tell you and the things that they don't tell you. So they're really the experts, and you're just providing that guidance there and that feedback. So it's important to know that. It's important to also know the difference between maybe when a client is venting versus they're actually sharing real intentions. So you need to kind of explore that more and ask some follow-up questions. It's also important to know that sometimes clients may say some vague statements of something like, we may meet next week or we may not, or I don't want to be here anymore. And those times it's important to see, is the person saying this because there's I thought our therapeutic relationship was growing and maybe it's not, and or I said something that may upset them or offend them, or are they actually planning to do something in the next week and we're not going to meet anymore. There are times also too where people will say, I don't want to be here anymore, and I'll say to them, so tell me what that means. Like, you don't want to be in this session anymore, we need to end it, or you don't want to be here anymore and like you don't want to live anymore. And some participants will like laugh like, oh, there you go, like, no, I don't want to be here anymore, and explain it. And then other people will continue with the vagueness, and that's when I'll start asking more questions. And, I've gotten to the point with some participants saying, like, I know you've experienced going to the hospital and going to the ER and what that's been like for you. And if that's a place that you need right now, I want you to be able to say that or feel comfortable that that's what we can do. If that's not a place, then I need you to talk to me a little bit more. And there's been some cases where maybe the rapport wasn't there and the person didn't feel comfortable. But in order to kind of do right by them, I've recommended ER visit, because you're not saying anything. You kind of know, if we don't have this information, what I have to assume, even though I don't want to assume. So, but my goal is that you always have to be safe, right? And so that's what I kind of stick back to when I talk to participants that are like, I don't really want to do this. And I say, well, once you picked up the phone, once you signed on to, the Zoom or the Teams camera, once, you stepped into the office, I took on that role to help ensure that you're responsible. And so this is my part of it. And then, depending on the situation, they might have the right to say like no, or there might be sometimes when people have to involuntarily go to the ER. So those are all things to kind of consider.
Yeah, thank you for mentioning that because it is important to kind of know as clinicians not to step in this with fear of not asking those additional questions or those responses that we get from our clients. So just as you mentioned, right, keeping in mind of, hey, this could be something that happens. Maybe they've experienced it before, just like you said, but also, can we talk about this a little bit further and provide that support if that's something that we could do? So again, always keeping this in mind of safety for the client, and having that conversation, and asking those further questions, just as you mentioned a little bit earlier, kind of seeing, are they taking their medication? Have they seen their doctor? Um, what are their daily activities? Sometimes it's questions that are within our assessment, depending on, where we're working. We get to ask about those activities. Um, are they taking a shower? What are their plans sound like? Or are there no plans? Um, so sometimes we see ongoing, whether it be isolation, disconnection. So there's this hidden risk, right? Um, so with this, how does social isolation show up now as a risk factor for our work?
So, kind of piggybacking off what you just said about the hidden risks, I think it's important to consider risk having layers and kind of peeling back those layers. And when someone doesn't have that support system or they're disconnected, that is usually a red flag. Like that's a concern. It's also important to find out if those supports they can be present, but are they helpful? Right. So there are sometimes where people are like, I'm married, I'm in the same room, in the same bed with my partner, but I'm alone. And so kind of, assessing what that means. There's sometimes where people are going through the empty nest syndrome, or college students are off and they don't want to tell their parents that they're being bullied, or that there's, a negative experience, or that they tried substance use, or a senior person who says like, well, people around my age, all my friends, they're passing away. My children and my grandchildren have their own lives. I don't want to bother them, things like that. So it is really important, to be aware that one, people might not have the support, but two, they could have the support present, but they're not always helpful. And sometimes it's also related to the fact that the participant doesn't want to impose. So it's like, yes, my daughter would come visit more, or my grandchildren would call, but I don't want to mess up their lives. And so sometimes it's kind of addressing some of those core beliefs and kind of saying, well, is how likely is that would be imposing for your grandchildren to call you once a month? That's something like that. So support is really it's key.
Yeah, thank you. Especially for those ideas to ask further on that support. Yes, someone's present, but what does that support actually look like? So thank you for sharing that. As far as risks, what risks are tied to chronic disconnection?
So usually tied to that is a lot of like physical health risk. Um, Especially when we talk about like medication. Sometimes people don't know what medication they're on, they're just taking it. Um, Maybe their sight or something is going, so they don't even know how much medication they're taking, things along those lines, as well as the mental health risk of just kind of being isolated and feeling, emotionally disconnected from other people and maybe even from yourself. Not, there's times where people say, I'm really sad or I'm really upset. And I know I have a reason to be sad or upset, but I'm so sad or upset, I can't even identify what like they forget what the reason actually is because it's kind of been a state they've been living in for so long. So I think that those are key risks. I also think in the virtual space, what we've been seeing is kind of an increase in people being taken advantage of. So a lot of online dating gone wrong, like where they're saying, this person lives in another country. I just have to send them a certain amount of money. I'm so excited for them to visit. And it's really hard because you do want them to be connected. And, we've had some participants that really didn't want to see they were being taken advantage of and have lost like thousands of dollars because of this. And then sometimes there's really no way to recoup it or or report it, of course, you'd identify APS, but there's not much necessarily that they can do. And so that's really where a lot of the prevention comes in, where I encourage people to talk to their bank because there's usually some type of financial expert at the bank that can talk to them about some of the dangers and some of the protections they can put in place. Because we have had people sometimes just share all of their information, their routing number, or their bank account. So it's just important to realize that feeling disconnected sometimes also makes people extra vulnerable, and that they might make choices and things that they wouldn't normally do.
Definitely always keeping those things in mind with clients or those conversations that can be a little bit more difficult to talk about. But thank you so much for explaining the support and going further into assessing client support as well as the chronic disconnection that's there. And you also brought up connectedness, right? Because that's important that we have that support, that we feel connected, that we feel understood and listened to. So I kind of want to discuss here that connectedness as a protective factor. I think you were getting a little bit into this as far as, speaking with our bank, having certain things that are set up. Um, but as far as connectedness with community, how do you see community and belonging as part of risk management?
Yeah, it's a huge part, right? And so that's like the blessing of the social worker. So being someone that has supervised other disciplines, a lot of times other disciplines are only trained in the clinical, right? So this is your diagnosis, these are medications that you can use, but the case management, connection to your community, to your environment, that sometimes is a struggle for other disciplines because it's just not how they naturally think. And even for some social workers, especially in the virtual space. So I live in New York, but I can be seeing someone in California if I'm licensed there as well. And so that really requires the social worker, if you're going to become licensed in multiple states, and now we have the compact and stuff that's, on the ground being worked on. When you do that, that you're making sure you still remain knowledgeable about the local community. So what are the self-help groups? Are there apps that people can join? What does that look like? So the social worker has to make sure that they're grounded in researching these things, and not just saying, for example, virtually, some of the programs are grief interventions. We do 8 weeks, we do 10 weeks. So it's important to know, well, after the 8 or 10 weeks, where is the person going to be connected to in their community? Now, I could say to you, Bonnie, here's Psychology Today, put in your zip code, and you're going to get people. You might know how to do that. You might not. You might actually go on. It's different for me to say, during this last session, we're going to take 15 minutes to go to Psychology Today, look at some of the profiles. That's a little bit different. So I think it's important, what they say, like whether you give someone the fish or you teach them how to fish, a lot of times doing those warm handoff calls and like those transfers, that's what is really helpful. And I think it helps people, one, to know how to navigate the systems of life, but two, it connects them to their community, it connects them to their next provider. And this is a place where I know sometimes social workers are like, well, I'm the clinician, I'm not really the case manager. Unfortunately, admin time, I'm not even paid for that, and they really struggle with that. And so that's where collaborative documentation and things kind of, I think, has its place, where we may not normally do that, but where we can say, hey, 30 minutes of the session, this is what we're going to focus on: session content and coping skills, and the last 15 minutes is like a wrap up, and where we're doing the calling and where we're learning, or where I'm even teaching them, how do you search, what is 211, right? What is findhelp.org, even chat gtp. So I think places like that in chat GTP, and they can be helpful, right? AI can be helpful in that way. It can be helpful maybe in saying, I'm going to be working in an African American community. What are some cultural considerations? It can be helpful, really helpful in that way. But it is important, and what I try to really stress to my students, that AI, though, can't replace you. So if I have to put into AI what to do in a risk management situation, by the time I've typed that up, that situation's probably already happened. Like it can spit out things to me really fast, right? But it's also not personalized. It's a general thing. So I think that even using AI and things like that as a part of the work we do, it has its place, but it's important that we put limits on what that place means and that we realize that there's still some responsibility for us to understand how do I connect this person to their community. And also, then how do I not only connect this person to their community, but ensure that they know how to be connected to their community when I'm no longer in the picture? Because that's our whole thing, right? Social workers are constantly working themselves out of needing to have a job, and so they're going to go on to someone else, and there's going to be like that's the cycle.
Yeah, thank you for sharing that. It is important to kind of take into consideration of where the client's coming from as far as what are they comfortable doing and what are they knowledgeable on. We can all be taught like how to do something, but it can be really nerve-wracking to put those steps into action. And so we want to take it a step further by providing that support, like, hey, let's get this started, or let's look what this website is like, and exploring that with them. So thank you for sharing that because it is important. And even that next step of quickly getting some information from AI to like really better support ourselves, or prepare ourselves for some of the things that we're doing. Um, as far as community too, sometimes this also looks like community as far as faith-based communities, peer groups, or even local spaces. What is it that that looks like?
So yeah, I agree with you that it can look like a number of spaces. And it probably sounds repetitive, but it was really just going back to the participant and asking what that looks like for them. What does that look like for them? What does that support? And then also, that's where I think it comes into cultural and identity and how personalized, because there are a lot of support groups found within that, and people don't always know. Um, when I'm doing risk management, sometimes at work, people will say, "Oh, this person has like chronic pain." And I'll be like, "Okay, well, is there a specific disorder? What is that? What is the name of it?" Because more than likely, there's chronic pain in general support group, but there might actually be a support group for their specific disorder. And so that is really helpful and I encourage them to attend that because there are certain conversations about medication and doctors that we will never have all the understanding of that people who have tried it will know. And again, sometimes it's clients are looking for like that personal touch. So I'll share sometimes like, well, I have trigeminal neuralgia, which I never knew what that was. And when I was finally diagnosed later on, I became pregnant. And so for me, I was like, I got to find a support group right away because I don't want to take medication and be having the baby, or maybe I'm supposed to take the medication and all of these things. And that support group, really helped me have a successful pregnancy. And so, like, that's something that's important to really help people too. Like, how do they identify? What are they looking for in support? What are their interests? So, silver sneakers, I don't know if they're still around, but that was a big thing for the like seniors to get them out and get them in community. The YMCA, other things. So it's just important to identify that of how they get involved. And for the youth, I can't stress enough for mentoring. Mentoring, and that's what I would also talk to some of the parents about sometimes too. When you talk about faith-based, uh, some of the fears that they have around that of I don't want to take my child to church, or I don't want to take my child to the community center because I'll be embarrassed. But we talk about, well, how maybe somebody in church could actually help support you, right? And kind of help you know how to pass on instruction and what discipline looks like, and all of those things. So I think it's having the conversation, and asking the questions, and then going from there. And there's also sometimes like lists that you can find online, like a list of 45 pleasurable activities, right? And you can ask people, which ones are you interested in? And then kind of go from there even and build their support.
Oh, definitely. Thank you for mentioning that. And I think as you were discussing it, I kind of came across the idea of practicing this on both ends for the clients and even for ourselves, because it is so important for us to just as you mentioned, like with the clients, getting to know specifically whether it be something they're diagnosed with, something that they're dealing with, having that support specifically around what they're going through, um, and maybe even for ourselves, right? What particular population are we serving that we get to learn so much more. Yeah, I've been through some of those experiences too, where it's like we get to learn so much more, where we educate ourselves, where we advocate. So yeah, it's definitely super important to kind of connect with those communities, giving us that next step of knowledge, of what to do that's best for ourselves or best for those around us. So thank you for sharing that. And all of this is so important. Um, and as far as what we're doing, what we're putting into action. But it's also important to document, right? Because if we don't document, it never happens, right? So how is it that we can go into kind of like that protection or clinical storytelling? So if you can share with us, how do you view documentation in the context of risk management, protection, communication, or even this clinical storytelling?
So the documentation is really key. It's important to, like, I know some clinicians that are like, I'm great with the clinical work, and when I'm in the room with my patient, I rock. I'm a top clinician. I just don't like those admin tasks, right? I just that's not me. And so I think it requires changing your mindset that like a great clinician really is able to marry the two. They don't see like admin and clinical as separate. They see them as a process together. And so it kind of goes back to social work 101. If it's not documented, it didn't happen. And what I, stress is have your documentation match your action. So you may very well know why you didn't call CPS or why you didn't involve anyone else. But if I'm a supervisor or I'm someone auditing that case, I need to know that too. So your documentation should explain like participant reported such and such issue. Therapist did not involve CPS or other authorities as there's another caregiver in the home. This is taking place when the child is at school, like something that would explain your actions. And then even a documentation as far as when we're talking about to um, going back to the previous part, when we're giving I guess, connection to virtual support groups or even face-to-face support groups, that we make sure that we document that, we vetted these resources and also that we recommended, encouraged, instructed the participant to also vet those resources, just so that that's documented as well. Because sometimes what works for one participant doesn't work for another one, and then they'll say, "Well, I got this resource from Bonnie, and so it's on her. It's not. I have that. If I didn't get that resource from her, I would have never had that experience, right?" And so it's important that you vet them, but that you then also tell them they need to vet them and then document that in the chart that that was something that you have done.
Yeah, definitely something really important to consider. And with all of this in consideration, we want to reflect on our ethics, our boundaries, and our clinical judgment, right? So, how do you balance ethical responsibilities with respecting the client's autonomy with risk being present?
So that is a great question. It is something that's hard to do at times, and I do think that this is when we kind of go back to looking at our policies, our procedures, utilizing our code of ethics, making sure that we're being open and honest in our own supervision, because that's the other thing too. Sometimes we may not share that information just because we feel like, oh, my supervisor is going to think I don't know what I'm doing. They're going to think I'm, inexperienced, or I've been doing this for 20 years, I should know, or I've been doing this for 5 days, I should know. So just really going back to all of those things, policies, procedures, state regulations is really important to know too. Just because there are times where you may believe something is reportable and your supervisor thinks it's not. And then what do you do in those situations? So lots of states have hypotheticals where you can kind of just call and say, you don't even have to say you're a social worker, just call the line and then tell them without providing any PHI, what the situation is, and they'll say like, yes, this is reportable. And then you say, I'm a mandated reporter, this is the information, or they'll say, no, it's not reportable. And then you too would want to document that, called with hypothetical, no PHI was shared, and what the result was. And if you really think that it's something that's reportable, you can also request, can I speak with a supervisor? And what I typically would do too, when they say, okay, this isn't reportable, I would ask follow-up questions of them and say, what would have made this call reportable so that I would know the next time I called or what have you, and kind of be how to document that as well.
Awesome. Thank you for those tips there, because it is important to consider all of our options, not only with supervisors, but also those phone calls we can make. And again, that extra question that we can ask, what would make it that way? So we can take that into consideration. So thank you for that. With that being said, that also brings up these red flags, right?
Mhm.
With what we might miss. So what is suitable red flags that you've learned to never overlook, especially when it comes to risk management?
Discontinuing medications is usually a red flag. Sometimes there's side effects with the medication, so being mindful of like what those may be. My own reaction to what a client is saying, or um, gut feeling. Also, impulse control. Clients that struggle with the impulse control is a big red flag. And then if someone discontinues attending like self-help, if they have a relapse, and then also what the research says. So sometimes someone can sit in front of me and say that they're not suicidal, but then or that they're not at risk for something else, but then when I look at the research, it says they fall in the culturally or ethnically, they're falling into that background. Their age falls into that background. They had a recent setback. I'm still going to kind of do a wellness plan or a safety plan or a relapse prevention plan, just again as a precaution, as a prevention.
Awesome. Thank you for sharing that. It is always it's so important to kind of consider those red flags in these risk factors because again, this can happen very, very quickly. And so we want to be hands-on with what's going on. Now we've had a lot of changes within our field when it comes to telehealth,
Yes.
hybrid work. Maybe there's, both, right? And so this comes with new forms of risks of assessing, and we've touched a little bit on it, but I like to get in a little bit deeper. How has virtual and hybrid practice really changed this landscape of risk management?
It goes back to like the layers that we've been talking about with risk management. It's important to do certain things like when someone's present in our office, we know where they're at. Whereas when I'm meeting with you virtually, I really need to confirm your exact location. Like, are you at home? Sometimes people will say things like, I'm at Walmart. Well, there could be tons of Walmart in New York. Like, I need to know the exact location because if I would need to call EMS or someone, I need to know where I'm sending them. And sometimes, if that's not the first question you ask, you'll have the session, and by the middle of the session, the person reports something that you need to that you now need to do something with, and they refuse to give you the address, or they say, "I'm going to go to the ER myself and drive myself there," which might not be the best thing to do. You need to consider what's the protocol if like the video goes out or if the phone goes out. Like, how are you going to get back in contact with the person? You need to confirm that the person's in a confidential space, right? And also a huge one is that they're not driving. A lot of times people will tell you that they're not driving, but you can hear the turn signal or any of those things. So it's important if there's intimate partner violence, it's important to check like if there's a safe word or if there's a conversational shift, like what you're going to be doing in those situations. So I think as we've been stating this whole entire time, almost hour, rapport is important. Like that's what you really need to do. And it's important to find out like how the patient is showing up, like physically, but emotionally as well.
Yeah, definitely. You have any tips and tricks on how to call the emergency line if we're not in the area of our client?
Yes, so there is it's like a national 911. You can look it up, and it'll tell you like if it's going to be calling this location or another location. But the other thing to also do is with the emergency contact, it's important to have an emergency contact for every participant. And then if they're high risk, I just recommend having a general release. So like maybe if, someone misses an appointment and you had some concern about them, that's not a reason to call an emergency contact, right? So it's better to also have a general release. So if they miss, you can just say, hey, this is Bonnie. You can let Shanisha know I've been trying to reach her and have her call me so that you feel good about it, but you also haven't done anything as far as like breaching confidentiality by calling someone you didn't have a release for, or if it was an emergency. Um, you said something else, I'm sorry, that really made me think. Can you repeat your question with something that I wanted to add?
Yeah, I had just asked on like how do we reach out to the
Yes.
emergency.
So also making sure that you have two modes of communication, right? So if I'm on here, I want to make sure that I have my cell phone so that I can be texting my supervisor or someone like this is what's going on and they can update me. If I'm using a phone session and I have my cellular phone, it's good to have a landline. Also good to be able to know how to put people on three-way and conference call. I'm shocked how many people don't know how to do that, but that's great to be able to know how to do that. And this is part of risk management too. A lot of us are using their interpreters and language lines to perform sessions. So really knowing like if we get disconnected and we need you, right, like what do we do? Kind of planning again, planning before it happens.
Thank you for sharing that because I have noticed it be a really big question that comes up. So I hope that this information was really helpful on what we do and being prepared, right? Having a plan in place. Now, from time to time, as a clinician, we have our own risks,
Mm.
right? We've talked a lot about client risk, but what about the clinician risks, like burnout, fatigue, or other things that you see?
So there are tons of risks there with, compassion fatigue, vicarious trauma, burnout. All of it's real. One of my professors once said to us, burnout was a choice. And at that time, I thought that was like rude. What did he mean by that? But now that I'm in the field, I really realize that what he meant by that is the clinician has to decide to put boundaries in place and really has to follow those boundaries and what that looks like. And so really thinking about that, and I think you mentioned it before, like that the saying of you can't pour from an empty cup. So you really have to be making sure that you're getting what you need for your supervision. If you're also being triggered by what your clients are saying, you need to be going to your own therapy. Like, there's nothing wrong with that. Think about it. We encourage people, we say things like anyone can see a therapist, anyone should see a therapist. And then you talk to a lot of therapists and they haven't. And it doesn't always have to be like your traditional LCSW or, your professional counselor. It could even be, a pastor, a rabbi, a close confidant, but something where you're able to release and then get some skills on how to prevent this from happening or deal with it when it happens. You need to ensure that you're starting sessions on time and ending them on time. There may become times I used to not like when people said you can't work harder than the client. That's not always true. Sometimes people are at a really low point and there's some extra effort that you need to get in and helping them to be empowered to do it on their own. But use your mind. Check in with your emotional and your heart, like, is this me actually taking over? Is this me going past self-determination and imposing my thing, or is this that this patient really does need this extra support and how do I provide them with that? Pay attention to your own stuff. Are you irritable? Are you becoming fatigued? Are there changing in your eating habits? Are you unable to sleep? Presence of anxiety, presence of panic? What are your family members and friends saying? Making sure you have a strong support system. I know it's important to identify what's your self care. For me, I go to faith and humor. I know that when not to offend or do anything like that. But I know for me, when God's at the forefront, no matter what I'm doing and all the places I'm being pulled into, I'm able to do it. When He's on the back burner, I'm unable to manage. And when I lose my humor and my laugh and I just feel down, there's a problem. So I have to kind of step away, and that's what I use. And that might be different for each person. So find out what that means. When you attend all these different CEUs, or if you're still in school, it's not that social workers want to make you little minions of themselves. It's that they're sharing their experience and you should pull from that, glean from that, and develop your own.
Yeah, thank you for sharing that because it is so important that we take care of ourselves and have various options, as you mentioned, like faith and you mentioned humor. We need to have a mix of what works for ourselves, because sometimes it can be really difficult, or we're going through something really hard and we need various options. Or, like I like to say, sometimes the weather's not so great that we can practice something outside, so we need indoor stuff too. So having good measure of like various things that can be helpful. So thank you for
Yeah.
sharing that.
And free
Um,
options because we don't always have the money to have paid things. So it's important to think of that too.
yeah, definitely. Thank you. Um, And so with this too, we have our own clinical intuition, right? Sometimes we're burnt out, so hopefully we're able to take care of that and come up with a plan there. Um, so that we can be in tune with our clinical intuition versus our clinical evidence. But these two vary, right? So how do you trust your clinical intuition when something's off, even if the assessment doesn't clearly show it?
Sometimes that comes from the rapport that you've built with the participant as well. Like I've had some clinicians share, when I do the PHQ-9, I do the Guide 7, the client is not reporting any symptoms, but verbally, when I'm talking to them just in situational, there's tons of things there. Like there's a huge discrepancy. So sometimes it's about highlighting that for the client. And sometimes that's also about being aware of the client's culture. For some cultures, it's important to put on a strong front. I am not allowed to express this. So taking those things into consideration. Also, I would just say routinely reviewing the risk factors, reviewing the protective factors, and then also looking at that prevention. So even though it's not showing up, I'm getting a gut that this is not okay. So let me just have this just in case. Talking to a supervisor again, seeing if there's any areas that you're missing. And then I think the conversation about risk management, it doesn't ever stop. As long as that person's in treatment, it's always ongoing. So as that continues to go on, kind of keep in the back of your mind, okay, this is a check, this is a check, this is a check. So I'm getting this gut, but I'm also checking off the list to say that it's not just my gut. I'm finding information, right? And I'm getting that information that's saying your gut is actually what's right. Um, and then just being proactive, remain proactive, and then sometimes also going that extra mile. So some states have like a universal release. If you sign this release, they can look up information with all the systems that you've interacted with. So if you have those tools, using those tools as well, because sometimes, especially with substance use, someone saying, I'm not using substances, they're coming up on the drug test, they're not using substances, but you just feel off. Well, sometimes when you check that universal release that they sign, you'll find that they're going to the ER to get the medication that you've already prescribed them. So they're getting extra and it's not showing up, but you had to trust that gut to look there. So that's what happens too is like and care coordination, right? If you have a release or consent to talk to the primary care doctor, to talk to the case manager, use that collaboration to see are there any holes, are there any gaps where I'm missing the information.
Yeah, thank you for mentioning all that. Working with your team, working very proactively, right? So with this, there's that risk management as prevention,
Mhm.
not this reaction, right? Um, so if we're approaching risk management as prevention rather than crisis response, what would you change or what things would you kind of give as advice to some of us who might be approaching it that way?
Um, I know it's going to sound repetitive, but it's really just making it a part of everything you do, right? That it's just a normal part of treatment. And so being proactive really looks like I know in one of the organizations that I work with, everyone gets a wellness plan. So they don't even have to have a risk factor, right? Everyone gets a wellness plan because there could be a breaking point that they haven't reached yet, that in between your sessions they reach. But if they have this wellness plan, they're already aware. Everyone learns about 988. Everyone learns about, resources that deal with housing and that deal with food scarcity. And so what I'll say to people is, hey, these are some resources for you or that you may pass along to other people who need them so that they don't, what you think I have a problem? Like, why are you giving me this? You're now helping them say, like, you're a resource to your community, which we talked about before. So that normalizes it for them as well. That I think is a piece, normalizing it, giving them the resources ahead of time. If you're in a physical office, having those things posted so anyone can read them. It's just there, it's available. If there's certain months, so sometimes there's like mental health awareness month or what have you, have resources geared towards that month to just share along with everyone. But the same way that when you meet with someone at intake, you're already thinking about, treatment planning, you're already thinking about discharge, even though that hasn't happened. You're thinking about that. Risk management needs to be at the top of that list as well. I'm already thinking about that. What are some potential risks? And it doesn't have to be my traditional CPS, APS, suicidal ideation, homicidal ideation. It could be the really high BGLs. It could be the really high blood pressure. And so that's why it's also important when you're working with certain populations, you do need to know some of this medical terminology. You just have to, because someone can say I have a BGL of 500, that means nothing to you until you Google it and you're like, oh my gosh, that's a really big deal, right? So that those are the things that you need to know. And I think you spoke to that again. I remember working with a population of students, and people were saying, oh, they're missing school and they're not being productive, but we found out later that they were missing school and not being productive because they were working in the farms because they had to pay the coyotes that threaten their families and their life. So it's all of these things. And sometimes you're not even aware that those things exist in your community because it's not something that's publicized or on the news. You're a small community that doesn't exist. You have to ask the question, not make the assumption.
Yeah, definitely. And I like that you mentioned small community. I think it's so important that as a small community, if we're coming from one or if we could be even in a bigger community, but really focused in on one small area, right, where we're working. So again, not being afraid to kind of look around and have these conversations with others, supervisors, mentors, things like that, because we can get more information as far as maybe what they've seen and kind of connect those two. Or again, talking with your team of the case manager, the doctor, the nurse, anything like that, just depending on where we're working, to kind of connect the dots there as well. So thank you for sharing all of that really great information. Um, to wrap up here on risk management, I'd like to just close off with if every social worker listening could change one thing tomorrow about how we change this approach on risk management, what should it be?
Prevention. Prevention would really be, if it was one word, prevention. And through that prevention, putting on magnifying glasses and really making um, your scope larger than this little area, but really everything. Because, we didn't get into this today because we only have an hour, and I'm watching the time, saying like, I got to talk faster, I got to get everything in. We didn't really talk about like the risk factors that can be environmental, right? Or the generational trauma that impacts risk factors, right? So we're looking at, again, a huge area, and that's what you really want to do. And then kind of part down to how it relates to this patient, because that's important. The whole preventative piece, it comes in when you're working with youth, right? The whole point of after school programs, prevention. So they're not home alone, right? So they're not having kind of like that latchkey. They're able to get that support. The whole thing around making sure seniors have their doctor's appointments and that they have their supports, prevention. The whole thing of making sure that college students who had mental health in when they're in high school, that when they go to college, that you call the college counseling department and you get them the counselor. Prevention, right? The whole thing of when somebody's moving from retirement, moving from working to retirement, and they're going through transition. Prevention, like it's constant, and really having that prevention and that lens, you want to open it up. It's not our traditional thing. What does this look like for someone else? And really quickly, just being mindful of what's impacting someone, that physical health. I've looked at cases where people were so focused on this person's had a suicide attempt, but no one's paid attention to the fact that she's not taking her blood pressure medication. She hasn't really visited her cardio. And then all these recommendations that maybe I could have provided or did provide as a supervisor, and the team goes back. They never had the opportunity to share it with the participant because the participant actually passed from a cardiac related issue. So we have to really look at that. Is that fault? No, it's no one's fault. Again, we can't control it, but it's just opening our lens and prevention.
Awesome. Thank you for having us keep that in mind. Again, that wellness and prevention measures, depending on our client, what that looks like. So I really appreciate you sharing all of these great insights. Maybe on the start of risk management, right? Like you said, there's so much more to it. And maybe another time we can dive in a little bit deeper because it is so important for us to have all of these great skills. Um, so I just want to share some great resources as far as where we gathered this information from. As we mentioned, ethics is so important. So we have some of the resources that we touched on here on our screen now that you can look into a little bit deeper if you'd like. Um, and as I mentioned, just a really big thank you to Sharnisha for sharing your clinical experience with us, and how it's evolved over time and how important it is for us to take care of ourselves and use that preventative measure for our clients around risk management. Is there anything else that you'd like to mention as we close off here?
I just want to thank you for this opportunity and just to remind everyone that people are different. Each individual has comes with their own needs, comes with their own risks, comes with their own protective factors, and people are also unpredictable. So just know that you're going to do the best that you can, that you're going to educate yourselves, you're going to research, and to make sure that you have those supports in place that will give you confidence. You know, we talked about some faith, support system, laughing, but you have to have your own. And if you don't, today's a great day to start looking for them.
Awesome. Thank you for sharing that with us. Well, you all have a great day. We have this hour of training completed for you all. So I really hope that you learned a lot from risk management, and we will see you again next time. Thank you.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.